Good morning, everyone. Thank you, Dr. Imad, for your nice presentation. From surgeon point of view, so today I will review the randomized trial and the guidelines and surgical practice consideration when it comes to why CABG remains the definitive revascularization for many of left main disease. So I know, can I control next, please? Yeah. So I have nothing to disclose. So why left main matters? So as we know, the left main coronary artery is the major artery and supplies more than 75 to 100% of the LV myocardium, reflecting its importance. And when we talk about here, like the ACS, left main in the ACS, ACS, as we know, that unstable angina is presented, unstable angina or patient with STEMI or non-STEMI. So historically, in patients with coronary artery disease, both PCI and CABG are viable options. However, CABG will offer reduced risk of reintervention, and it will be offered for patients with complex anatomy, and it will achieve the complete revascularization. As compared to when it comes to the PCI, yes, it will offer a fast recovery, and it's better for patients who have hemodynamic instability or STEMI patients, and less invasive. However, there is increased risk of restenosis and repeat revascularization. So the gold standard for long-term complete revascularization in high-risk patients remains surgery. So the current guidelines, it's for patients with left main disease. We're talking about general left main disease now. It's a class 1 recommendation for unprotected left main, especially patients with a high complex syntax score or multivessel disease with diabetes. PCI is a class 1 as an alternative for low complexity left main disease. And when we look at the guidelines of the European Society, they recommended the CABG over the PCI for patients, as we see here, in the patients with reduced ejection fraction, diabetes, or contraindication for dual antiplatelet. And when it comes to the anatomical and technical consideration, if the patient has a distal or bifurcation lesion or the presence of multivessel disease or high anatomical complexity. And we have to see if the patient's like now presented with a left main stenosis. So what's the percentage of patients who will present with a distal left main? So the majority of those patients, actually, they will present with a distal segment left main disease, almost like 61% as compared to the midshaft or ostial lesion. And when we talk about, what about the isolated left main coronary artery disease? So isolated left main coronary artery disease occurs in only 4 to 6% of patients with left main disease. And this was published in JACC from the Interventional and Cardiac Surgery Leadership Council. And again, it shows the same, like when they recommended the CABG, they recommended the CABG over PCI for patients with left main disease. So moving to the trials, what the randomized trial shows for patients with left main coronary artery disease. So let's focus on the largest and most important trials, such as Excel, Noble, where they include patients with unstable angina and non-ST elevation MI, pre-compact, and the pooled review evidence. So when we look at the Noble, they reported the 5 years outcome was inferior to CABG when it comes to MACE at 5 years, mainly driven by more non-procedural MI and repeated revascularization. Although it was presented at the last TCT meeting, the 10 years outcome, and it shows actually all-cause mortality was similar when it comes to PCI and CABG. However, they didn't publish the composite outcome, which was the main primary endpoint of the study, which was composite of mortality, acute MI, and stroke and revascularization. Excel, in patients with unprotected left main who have a low to intermediate syntax score, was not inferior to CABG, with similar rate for composite death endpoints. However, when we look, then moving to the syntax, the same 14 years outcome. However, when we look at the subgroup analysis of the syntax score, although the main primary composite endpoint, it didn't show significant difference, But when it comes to the subgroup analysis, when it comes to the three-vessel disease, patient with multivessel disease, or patient with diabetes or high syntax score, it's all in favor of CABG in the subgroup analysis. Moving to the pre-compact trial, again, it didn't show statistically significant difference in the composite endpoint. However, when it comes to the subgroup analysis, it's mainly in favor of CABG in patients with, again, diabetes or distal left main disease or left main with three-vessel disease. Moving to the meta-analysis. Meta-analysis, one of those latest meta-analysis study included 4,500 patients, 5 randomized trials, and 5 years of follow-up. All-cause mortality in comparison between PCI and CABG, they were the same. In terms of the stroke rate, the same. However, myocardial infarction and repeated revascularization was higher in the PCI arm. So there are trade-offs, and they are real when it comes to the PCI. I know it's less invasive, shorter recovery, fewer early complication. However, CABG will offer fewer re-intervention and lower late MI and better durability. And when we focus on the repeated revascularization, this is not a benign phenomenon. And consistently, it was higher after the BCI. Roughly, we're talking about 2 to 4 times higher. And the author of the Excel trial, when they went back and look at the mortality after those patients' population who have underwent repeated revascularization following PCI or CABG for left main disease, it was statistically higher, significant in the PCI group, and those patients will impact their mortality on the long term. So which patients benefit from most from the CABG? We're talking about high anatomical complexity of the syntax score, multivessel disease and diabetes, and if the patient prioritizing durability and freedom from repeated revascularization. So what else makes the CABG better than PCI for treating left main? PCI treats the isolated lesion in the proximal vessels, where CABG will bypass the proximal 2/3 of the vessels, where the current and the future threatening lesions will occur. So this makes the best option of a CABG, even if the stent restenosis is 0. So who's treating the left main disease? Actually, it's a heart team approach, in informed consent, explaining the risks and benefits of each option, patient-centered care, and shared decision-making. So it's a collaborative effort of both disciplines. This is needed for the heart team to success, which ultimately will give the patient the best option and will provide the best outcome. So it's not a cardiac surgeon versus cardiologist, it's a cardiac surgeon and cardiologist. Thank you.